positive-derived erythroid cells. As well, 24 hours treatment with SH6 also downregulated or degraded the BCL11A as well as ZBTB7A. Its effects also abrogated in the cerebron E3 ligase lockout, not knockout in HuDAP2 cell line. Now, just to as to set the context, is that the cerebron was the abstract in a plenary session a couple of years ago at ASH. In addition, there's a synergistic effect with the cytidine, and they also, SH6, in addition to activating fetal hemoglobin, it was also able to activate epsilon and zeta, which are much more primitive forms of globins. So this has the potential of rescuing not just sickle cell disease, but perhaps other types of hemoglobinopathies as well. Now, moving away from fetal globin-inducing agents, let's move on to crizanlizumab, which many of you know well. A trial which demonstrated there was differences in pain crises between the 5.0 milligram per kilogram versus placebo. That was the SUSTAIN trial, and then in the phase 3 study, the STAND trial, where they compared the high dose crizanlizumab, the 7.5 milligram per kilogram, to 5.0 milligram per kilogram to placebo, that there was no statistical significant difference. Now, nonetheless, the study continued in children ages 6 to 12 years, and this is the phase 2 SOLOS KIDS study, the primary data readout. And you can see here that the study went on for 2 years for each of the child. Patients need to have a confirmed diagnosis of sickle cell disease, as well as at least one pain crisis within the preceding 12 months. And what they found is that in the PK/PD profile, that the 5 milligram per kilogram crizanlizumab in pediatrics was actually lower than the predicted dose in adults, but 8.5 milligram per kilogram higher than the predicted adult exposure at 5 milligram per kilogram. And in addition, pyrexia, abdominal pain, and headaches were the most common side effects. But more importantly, though, in the children, rather than not seeing a difference, there was a reduction in painful vasoconstriction episodes leading to healthcare visits, as well as hospitalizations and emergency department visits. And you can see here that there was a reduction in both the 5.0 milligram per kilogram group, as well as in the 8.5 milligram per kilogram group, suggesting that there is possible efficacy in this setting. Last but not least is pyruvate kinase activation. Now, just to give everybody a background, pyruvate kinase activators act on the last enzyme of glycolysis of pyruvate kinase. And the purpose of it is to increase the amount of ATP production inside the red cells, so as to reduce the oxidative stress that these red cells are experiencing, and also to improve the general health. But more importantly, in sickle cell disease, as we all well know, is that there is an increased amount of 2,3-DPG. And the increase in 2,3-DPG means that the oxygen dissociation curve is redshifted, or the p-value is actually increased. Now, what's bad about that? Well, it's because if you start losing oxygen, then there's a higher tendency for the sickle hemoglobin to polymerize, causing sickling. So we wouldn't want that. So one of the salutary effects of using a pyruvate kinase activator is that we can increase the glycolytic flux through the glycolysis pathway, and therefore we can reduce the P50, or shift the oxygen dissociation curve to the left by depleting 2,3-DPG. Well, that all sounds very nice, right? Theoretically, well, how does it work? Well, you can see here that in this one-to-one randomization study, that regardless of whether it's an intent to treat population or per patient population, that there was a improvement in annualized VOC rate anywhere from 45% to 63%, and that there was an increase in hemoglobin on the right-hand side, as well as a slight improvement in the PROMIS fatigue score. All these new agents available, if we are not able to diagnose our patients and provide them access to care, they won't ever be able to access these new agents. So, how can we get improved diagnosis and access to care? We can see here abstract 541, which is the ASH Consortium on Newborn Screening in Africa. initial results. So CONSA was established in 2018 by ASH, and the primary objective was to determine the population-based birth incidence of sickle cell disease as well as the effectiveness of early standardized care in preventing early mortality in children with sickle cell disease. And then you can see here that of these 73,000 patients that were screened by isoelectric focusing gel with a confirmatory test, that there was 1,055 patients diagnosed with sickle cell disease, but only 37.16% of patients were linked to care. So then the question is, why was only 37% or approximately 1/3 of the patients that were linked to care, even though there was a comprehensive diagnosis amongst a very large population of newborns? And so the next abstract probably can answer that question. And in this abstract, abstract 392, determinants of linkage to care in newborn screening care program for sickle cell disease in Ghana. Here, they ask the question, what are the barriers and facilitators to linking the newborns to the clinic? And here, they have a birth prevalence of 1.36% of 4,121 newborns. And all the families agree to be enrolled, but only 62% attend the 6-week appointment, very similar to what we've seen in the previous abstract. And what they have found is that the factors that influence attendance include primary caregiver having completed university or higher, the distances to the clinic, the genotype of the patient, and what they thought is that both low disease literacy as well as disease stigma appears to play a role in preventing linkage to care. So perhaps these are the areas that we can focus on in the future in both research as well as practice. Next is, can patients exercise? So now that you have a patient, right, you're treating them in the clinic, and often patients now come to me and ask, well, can I exercise? And in this case, a 43-year-old male with sickle cell disease with 2 painful vasoconstriction episodes, no history of obstructive or restrictive pulmonary diseases, and no osteoporosis, on hydroxyurea maximum tolerated dose, recently diagnosed with hypertension, started an angiotensin receptor blocker. He was advised to exercise more. This morning we all talked about with Dr. Thompson that, we all encourage patients to exercise. And patient is concerned because he has sickle cell disease, whether he can exercise or not. And so this abstract, 604, may be able to answer that question. The Sickle Fit Test exercise programs for older adults with sickle cell disease. What they have done is that they have taken 24 adults and put them on an exercise regime that was adapted from GeroFit, another exercise program for 3 days a week for group exercise program. There was 8